Hello and welcome back to episode 1, season 3.0 of Medical Today. With me, Bernama. From laser, we now move on to cardiology or to heart problems. Well, most of us don't know this, or most of us actually read about it all the time, but don't know that heart problems or cardiovascular problems is one of the leading causes of death in Malaysia, one of the leading problems of health in our country. Now, a lot of conversations surround cardiovascular disease, and these conversations need to continue in order for us to get a better understanding of what it is and how we can change our lives to stay away from cardiovascular diseases. Now, joining me is Dr. Chee Kian. He's a consultant cardiologist from KPJ Tawakkal KL, or it's Tawakkal Specialist Hospital in Kuala Lumpur, joining me to talk about cardiovascular diseases and correctable problems. Doctor, thank you very much for taking time off to be with us. It's great to have you here on the show. Now, I'm going to get straight into it and ask you the principles which causes heart diseases. What are the principles or the underlying principles behind heart problems?
Thank you very much, Gerald. When we talk about heart disease, the main bulk of heart disease in the world today is actually coronary heart disease. So the principal or main causes of coronary heart disease are hypertension, diabetes mellitus, dyslipidemia or high cholesterol, smoking, obesity, physical inactivity, and of course the familial or genetic factors. These are the principal causes of coronary disease.
Right. When we talk about preventing cardiovascular diseases, you just mentioned hypertension, and this is something I've been reading a lot about as of late. Now, it's very easy for us to say, okay, to prevent hypertension, you need to do this, this, and this. But a lot of this goes back to stress at work, and a lot of us have to go to work. Now, this is one of the contributing factors or one of the major factors within hypertension in Malaysia. Of course, the bad diet is another thing altogether. But what are your thoughts on this?
Hypertension is generally a disease, a silent killer. All right, okay. I think it has got a lot of the thing to do. It's a multifactorial risk factor. It can be related to familial or our genetics. It also can be related to our lifestyle, our salt intake, our modern diet. So hypertension is one of the main causes of coronary artery disease, which we need to tackle to prevent coronary heart disease. As we tell all our general population of patients, we must know our number, which is the blood pressure number. What is an important number to remember? I think for all purpose and intent, for all ages, we try to tell every one of our population that you must aim for a blood pressure of less than 140 by 90 millimeter mercury.
140 by 90. But saying if you have a risk of a heart problem, or if you had an infarct before, that's still not ideal, isn't it? You need to bring it even lower.
Yes, generally there are two guidelines in the world today. If you take the European guideline, they will say that anything less than 140 or 90 millimeter mercury would be quite acceptable. The American guidelines have gone even lower, and the Americans say that you should actually aim for less than 130 by 80 millimeter mercury, because we must remember the risk is a continuum risk. It's not a number. It's not above 140 or 90 you're going to get more heart attack. It's actually a continuum. Your risk of getting a cardiovascular event increases every moment after 130 by 80 millimeter mercury. So it's a continuum risk rather than just a number.
But it's interesting that it has to come out from the mouth of a cardiologist rather than a primary healthcare physician, because hypertension starts from primary healthcare. Are we doing enough at primary healthcare to ensure that by the time they get to you, they at least understand what systolic and diastolic is?
That's a very interesting question. I think what the cardiologists in this country or in the world are doing nowadays are actually to educate our primary health providers, our GPs, our family physicians on what is the blood pressure target that we are trying to aim for. I think at the end of the day, screening our population properly make sure that they get the definition of hypertension is correct, make sure that they are being treated properly to bring it down to an ideal blood pressure of less than 140 or 90. And I think this has been what the National Heart Association of Malaysia, or the NGOs, National Foundation of Malaysia, or the hospitals are trying, Ministry of Health, are trying to educate the public as well as our primary health providers.
Now, if you look at the age or the median age of a person afflicted by heart disease or getting a heart attack, they're getting younger and younger. I think your youngest patient, correct me if I'm wrong, it was 19 years old?
Yes, yeah, as told to you just now in my conversation, my youngest patient who suffered actually a heart attack or acute myocardial infarction was 19 years old.
Acute myocardial infarction with destruction to anterior or posterior?
Yeah. Acute myocardial infarction in a layman's term is heart attack.
Heart attack.
When we talk about a patient who has suffered a heart attack, what it means is that there's
muscle damage.
Death of a part or portion of the heart muscle due to inadequate blood supply. As told just now, my youngest patient is actually who suffered a heart attack is a 19-year-old. He was a rugby player, and his risk factor was actually dyslipidemia, or very high cholesterol, as well as obesity. So it comes as no surprise that I think age is no more the so-called limiting thing that you will not get a coronary heart disease.
Right.
Because as you can see, coronary heart disease is a disease of the modern world, a disease of the 20th century. Hypertension, diabetes mellitus, which is actually the major coronary risk factor, as well as obesity, physical inactivity, and of course the one of the culprits which we really should actually stop is actually smoking.
Smoking, yeah. So I think when you talk about lifestyle changes, all of us talk about lifestyle changes, and the most of us in Malaysia are looking for that one pill that will cure all our problems. That's never going to happen. Lifestyle changes has to be made. And for those of us who smoke, I think the biggest thing is to give up smoking. There are many ways of doing that. There's cessation clinics also, a lot of them in public and private hospitals. So many things we can do. But when it comes to eating, this is a problem to us because we don't eat to live, we live to eat. That's the Malaysian way. Now, what would be your advice in ensuring that you're eating decent portions or decent meals on a daily basis? Of course, eating purely healthy food is very expensive. We can't do, some of us can't do that. But what would be your go-to standard advice be?
My standard advice for all my patients and also for the general public is that everything to be eat sensibly, eat moderately, okay? Cut down on your sugar intake. You have to cut down on your salt intake. We eat a lot outside, okay? So some of the things that is beyond our control. But when we are at home, okay, we should adopt all this healthy lifestyle, so-called cooking. This fast food,
is something you should stay away from.
We should try to reduce it, and also I think the important thing is actually the sugar and salt intake. All right. I think that is the two
sugar and salt intake.
Sugar and salt intake,
because that leads to
diabetes
and hypertension too.
Exactly.
Right. Now I'm going to read out something to you. This was given to me by the producer. Our heart normally beats about 60 to 100 times each minute, but sometimes it is out of rhythm, which is irregular. What is the first thing we should do when irregular heartbeats or palpitations, or we do experience things like this?
It's very interesting. Palpitations is a very common symptom among patients that come to see the cardiologist. By definition, by strict medical definition, palpitation just means that awareness of one's own heartbeat. But to a patient, palpitations means they feel that their heartbeat is beating faster and irregular. Most of the time, the patient that comes to us with a so-called palpitations, they are found to have normal sinus rhythm or normal rhythm. But as a person age, when the patient complains of irregular heartbeat, we have to really rule out a condition, an irregular heart rhythm condition called atrial fibrillation. Because atrial fibrillation predisposes to stroke or cerebral vascular accident. In the younger subset of patients, generally, a patient who come in with a real awareness of a fast heartbeat and feel very unwell or giddiness, one of the arrhythmias or this abnormal rhythm situation that we need to rule out is a supraventricular tachycardia in the younger subset.
Supraventricular tachycardia. Yeah.
There's a abnormal accessory pathway in their heart conduction system. So these are the two main things that we have to rule out: an atrial fibrillation as well as a supraventricular tachycardia. Now, of course, they are all more dangerous rhythm. Okay, the ventricular arrhythmias and so-called and so forth. But generally, the patient who is well enough to come to see you, who complain of irregular heartbeat, atrial fibrillation should be ruled out. All right.
Now, here's a very interesting question. What is the difference between between heart disease, a heart attack, and heart failure?
That's a very interesting question. When we talk about heart disease generally categorized into a few major entities. The majority of them is actually coronary heart disease. The other entity of heart disease are the cardiomyopathy, diseases of the heart muscle, weakening of the heart muscle, which can be due to a lot of factors. Again, coronary heart disease being the major cause, besides virus infection, substance abuse, so on and so forth. Now, the third heart disease entity is arrhythmia, like the irregular of heart rhythm. Arrhythmia is one big the disease entity that we deal with. Okay, the other one is of course the valvular heart disease or congenital heart disease, the hole in the heart. That's another entity. All right. Now, when we talk about heart attack, we are talking about acute myocardial infarction. That means there's a death of a portion of the heart muscle due to inadequate blood supply. The third one is of course the heart failure. When heart failure is actually an entity whereby the heart, the left ventricle, failed in its capability to pump blood out, and this leads to heart failure. Heart failure can be due to a lot of causes as well.
Right, that's a very interesting explanation. But here's another thing. A lot of people talk about a cramp in the heart. Does that actually happen?
Now, this so-called term of heart cramps actually is a layman term for a cardiologist. Is actually a coronary artery vasospasm, a sudden constriction of the coronary arteries, the arteries that supply blood to our heart muscle.
Right. How dangerous is this?
It's actually most of the coronary artery vasospasm are actually due to atherosclerotic, pre-existing atherosclerotic disease as well. But there are also certain entity or certain condition whereby the heart, the coronary artery constrict on itself with no evidence of blockage, no atherosclerotic, okay? And these are actually due to the muscle hypersensitivity, and there are also medications to solve the issue.
Now, when you get a heart attack, or when you think you're having a heart attack, you go into the emergency, a few things happen, okay? They go there, they do an ECG on you, they check you out, they also do a TROP-T, I think the doctor can explain that. A TROP-T is to see if a certain enzyme is released into your blood upon a myocardial infarction or a heart attack, little things like that. So if you understand the process of what happens at emergency, maybe that'll shed light on, what happens when we go to the hospital. So saying if I have chest pains now, I walk into a hospital, what happens immediately?
All right, when typically a patient who come in with a chest pain to the, let's say, the accident emergency department of any hospital, here will be triage, So now the doctor will see the patient and get a proper history and get the so-called the symptom of chest pain. How is the chest pain like, and of course an ECG will be done. The ECG is of utmost importance because it will be able to tell us whether this is a ST elevation myocardial infarction or non-ST elevation myocardial infarction, what we call in a layman's term a true transmural heart attack that affect a big portion of the heart, or just a small heart portion of the heart muscle. Now, of course, we will take a blood test, the cardiac enzymes, and of course the highly sensitive troponin T or troponin I. These are very sensitive enzymes.
What's the difference between a TROP-T and a TROP-I?
It's about the same actually. Yeah. It's actually a enzyme released by your heart muscle when there's a so-called necrosis of death of it due to inadequate blood supply. It's very sensitive. You'll be able to pick up whether you even suffered a minor heart attack. And once, let's say, if the ECG showed that you have got a ST elevation myocardial infarction, it becomes a very important thing for us, a cardiologist. ST elevation,
yeah,
because you want to bring the patient in a PCR, in a angioplasty equipped hospital with cath lab. You want to bring the patient as soon as possible to the cath lab for primary angioplasty. You want to do an angiogram and you want to find the blockage and you want to relieve the blockage as soon as possible because time is muscle. Every minute lost is death
muscle damage.
Muscle damage. You do not want the patient to end up with heart failure.
Right.
Of course, in hospital that don't have a cath lab, they can always thrombolize the patient with medications that actually dilute the blood and try to relieve the obstruction. So, of course, if you are proven to have a heart attack or myocardial infarction, the drugs that the medical will be given in the A&E will be an antiplatelet, aspirin, and of course all the other
clopidogrel, aspirin,
yeah, ticagrelor, okay, yeah, no, and pain relief. Remember, a patient that come with a heart attack really have got very severe chest pain.
Right.
It is out of this in the description in their own words is something they've never felt before, and they feel that they are dying. Okay, they cannot describe to you the feeling. Yeah.
Now, very interestingly, you talk about medication. We just talked about blood thinning medications and all the medications to kind of help you survive or live around heart problems. Now, the other problem is alternative medicine has come to say that whatever that's being given by a doctor or which is given by a doctor is stuff that you can't take long term. And I think there's a lot of studies being done. Of course, the risks are also looked at all times, especially when you're giving out antiplatelet medicine and also giving out cholesterol medication. Yeah, it has its risks, but that risks, have been taken into account. Yeah.
All right. Now, if a patient has suffered coronary heart disease, okay, he or she should remain on an antiplatelet agent for life, lifelong, long term, as well as a statin. Statin is a medication to bring down your cholesterol.
Right. While you're talking about statins, while you're talking about statins, very quickly, a lot of people say now that cardiologists give out statins and also CoQ10 in order to help with the body aches, so on and so forth. Is that true?
Okay, that's a very interesting question. Okay, as you know, maybe in a minority of patients who is taking statin, they develop a muscle ache. Okay, muscle ache is one of the known side effects of taking a statin. But and anecdotally, there are reports that says that if you take coenzyme Q10 along with a statin, it might reduce your chances of getting a muscle ache or even reduce the painfulness of a muscle ache.
Or fatigue, they say?
Or fatigue. Yeah. I think jury is out there. It's no definite evidence-based medicine for that, but certainly anecdotally, some patients feel that they felt that their muscle ache is less.
It's so interesting that you say this because I really need to bring this up, and I didn't tell you about this, but we really need to talk about, a lot of people are going and saying that you need to take high doses of vitamin C if you have heart problems. Now let's hear it from the cardiologist. What do you say?
I'm a cardiologist that's evidence-based. Evidence-based. I think all doctors should be actually practice evidence-based medicine nowadays. Vitamin C, again, anecdotally, there's no well randomized trial, large trial to actually show that.
You're looking for the double-blind, randomized,
placebo control. So I think again, these are all just anecdotal report and not really proven.
Right. Now, does having CVD increase the possibilities of having a stroke also?
Definitely, because if you got a stroke, can be the main. There are two types of stroke: the ischemic stroke or the stroke due to blockages of your cerebral circulation, or the hemorrhagic stroke, or bleeding stroke. The majority of the stroke is actually ischemic stroke or due to blockages. The same risk factors that causes blockage to your coronary arteries are the same risk factors that causes blockage to your cerebral circulation. So if you have got coronary heart disease, your chances of having a cerebrovascular accident is increasing.
So if you don't want for this to happen, if you see this little model here, and if you don't want for this to happen, what should we do? Essentially, taking medication and having a proper diet. What would be your advice before we end the segment on cardiovascular disease, what would be the thing you tell people all the time?
I think I tell people
Your mantra.
Yeah, I tell them, there's never a age where it's young enough for you to get a medical checkup or a medical consult. Go for regular medical checkup. Okay, know your blood pressure level, know your cholesterol level. Make sure you are not diabetic. All right. Okay, and exercise. You must do exercise and avoid obesity. And if you smoke, please stop smoking.
Okay, now that you mentioned diabetes mellitus for the third time, I need to ask you, what's the world standard now? When are you pre-diabetic and when are you diabetic? Now they say it can be reversed. What are they meaning by reverse? When it's reversed, you can't go back to the way you used to eat, innit?
You see, we know that actually when a person is diagnosed as diabetes, that means his fasting glucose level is more than 7 millimole per liter, or HbA1c of more than 6.5%. The HbA1c is the average sugar of 3 months. These are what we use to define a diabetic nowadays. When we see a patient with diabetes, we know that historically this didn't occur overnight. The pre-diabetic has occurred many years before that. We hope to catch the population before they reaches the diabetic, right. Okay, and we always tell them actually to watch their weight, okay, know their sugar level. You do not want to reach your HbA1c of more than 6.5% before you see a doctor,
right?
All right, I think that's why it's so important to get regular medical checkup.
So it's very interesting to note that when you take care of yourself, a few things you have to look at. The first thing is your sugar levels. Always go get your lipids done, which is your cholesterol blood test. It's a very simple blood test. It's only about 30-40 ringgit. If you go anywhere, you can find out. Most labs have it. Do your A1C, that's very important. It shows you your sugar for 3 months. And anything else to add on to that?
I think that's my mantra.
Yeah, that's your mantra.
Yeah, all right. Okay.
So that's all we have on this segment, talking about, of course, the very interesting subject in Malaysia, which is cardiovascular disease. Joining me was Dr. Chee Kian, who's a consultant cardiologist at KPJ Tawakkal KL Specialist Hospital. Doctor, thank you very much. It was a pleasure and an honor having you here.